Well, it's really nice to be back. I must say that OEIS is probably my favorite meeting of the year. Excellent. I have no disclosures. Just to give you a little historical, as Kavi mentioned, we've been doing fibroid embolizations in the outpatient world for quite some time now. Gary Siskin from Albany presented many years ago, over 20 years ago, his experience. 49 patients, 47 of which went home the same day. A couple spent overnight, and they didn't have any bounce backs. Leah Amir and I published our experience a little later, a bigger series retrospectively. We looked at 514 patients, all done by me, and 501 went home same day. We had 13 do overnight, still 23-hour OBS. And we didn't have any bounce backs. So to talk about our OBL, we opened 8 years ago. We've done almost 6,000 now UFEs. Everybody goes home same day, within 4 hours of the end of the procedure. We do have some people bounce back, a very small percentage. I think it's the ones that we would have done 23-hour observations on in the past. We just bring them back to the center. Usually it's next day. For pain control, and give them a couple hours of pain control. Maybe it's fluids and nausea medication, and then they leave and they never come back till their follow-up 3 months later. We've had a couple of people where we were a little skittish about sending them home due to blood pressure issues. We had one contrast reaction. Again, these patients had some observation in a nearby hospital and were sent home that evening. So what are the prerequisites if you want to do this? I think, as Kavi mentioned, you want to have experience with UFE. You know, you're in the OBL setting, you're on an island, you're not in a hospital setting any longer. So you need to have some experience with UFE. I think it's really important to set the appropriate expectations, not only with the patient in the office ahead of time, but with hopefully a family member that comes with them. It's amazing what patients forget if they come by themselves. I think MRI pre-procedure is absolutely critical. You'll see a lot of people doing this just with ultrasound, and I think it's a disservice to patients because you can get away with it, but it's not best practice by any means. And I think you need to have a defined protocol for post-procedural calls and post-procedural symptoms that can arise. So we'll go through each of those. So with respect to experience, as I mentioned, you kind of want to be comfortable doing UFE. But if you're starting out in the OBL, this is the kind of patient you want to do the low-hanging fruit. They're symptomatic. They have multiple small to mid-sized fibroids. They're not terribly obese. They don't have a lot of medical comorbidities. Their uterus is at the umbilicus or below. They're not interested in any fertility. Then they don't have intracavitary fibroids or significant submucosal components, and they don't have adenomyosis. That's a perfect patient to do in the OBL, even if you don't have like tremendous experience with this. As I mentioned, you got to set expectations. The consult is between 30 and 45 minutes, and it's important to emphasize with the patient, because there's a lot of disinformation about fibroid embolization in the community. People are always Googling all sorts of stuff, and people come into the office with all sorts of misinformation. But the success of UFE is not determined by how much these fibroids shrink. And that's really important, because while we typically get a lot of symptom reduction and a lot of size reduction, sometimes the size reduction doesn't come along for the ride significantly. And you don't want people to be disappointed. I've had patients go to the gynecologist after a procedure, say a couple months later, and they do an ultrasound and they get a frantic phone call. My gynecologist said my fibroids are back, and we talk about symptoms. All the symptoms are gone, but they're focusing on the fact they still have fibroids. And so if you don't set the expectation of what's going to happen, you get patients that are confused and think the procedure didn't work when all the symptoms are gone, and that's the reason why you did this. You got to know for the patient what they need to call about after the procedure and who to call and when. And it's not the OBGYN. Obviously, that nothing gets the OBGYN's hair on fire if you like start giving them their number to call after a UFE. And you need a protocol for the bounce backs. It doesn't happen very often, but you just got to know, the patient's got to know what to do, and you've got to know what to do when they come back. And this results in much fewer calls, much higher patient satisfaction, and overall lower costs because they don't end up going to the ER. You don't want these patients going to the ER. That adds a lot of unnecessary cost. MRI, again, I think MRI is critical. We use the coronary T2 weighted in the angio suite. We're looking at it next to the selective uterine angiography, and that's really important to do. I think you have lower failure rates, lower dose. You don't do these post-embolization angiograms looking for it. You don't need to. You have your selective uterine angio and you got your coronary T2 weighted, and you go, okay, oh, there's a fibroid up there and there's a bare area. Likely there's going to be an ovarian, and you can go after it in patients that are not interested in future fertility. You need to know about adenomyosis, and ultrasound does not do a good job with adenomyosis. It misses it commonly. We've had patients sometimes for years have been followed by ultrasounds, and they have a diagnosis of fibroids, and I have to explain to them that they don't have fibroids at all. They have diffuse adenomyosis, they have uterine enlargement, but their gynecologist did a crappy office ultrasound and gave them the diagnosis of fibroids even though they didn't have fibroids. And the presence of adenomyosis will change what you do. Sometimes you might see adenomyosis diffusely on one side and fibroids on the other. I'll use different embolic to address each of those. And you got to know, is the adenomyosis more the issue here, or is it fibroids more? And that might change what you do. And if you have central fibroids, you have a big FIGO type 0 intracavitary fibroid, not the person you want to embolize if it's above, say, 3.5 centimeters, or a combined volume of 21 cubic millimeters. You're going to need to do a combined approach because you don't want these patients aborting a fibroid, particularly if they're nulliparous. That's pretty brutal. You need to know about adnexal pathology, which again, ultrasound commonly misses. Reed or Mari published a nice paper on this, and 22% of the patients had their clinical management changed just based on the MRI. You need protocols. The first thing is you need to be available. All the patients that we see have my cell phone, and they don't overuse it. They're reassured, actually, that they're not going to, if an issue comes up, they're not going to call somebody that's covering or a mid-level or what have you. They're getting you. It keeps people out of the emergency room, which, again, is costly. You get unnecessary imaging and sometimes even unnecessary conclusions from radiologists looking at a post-UFE CT scan of the abdomen and seeing nitrogen and thinking it's a pyometra. That's a nightmare. Post-procedural pain. Yes, these patients do get pain, but we've gotten a lot better with a standardized pain protocol that we've been tweaking over the years, and so less numbers of patients have these significant pain issues, but you got to understand it. Traditionally, during the procedure, we'd give conscious sedation, fentanyl, Versed, and then plug these people into a PCA pump and keep, send them for 23-hour observation. That's just not adequate any longer. You need a really established protocol, and there are some certain things that have been proven to be effective, and you just need to establish it and see what works for you. But Rob Kirsch showed this pain curve over 20 years ago. Pain at that time was immediate. Time 0, patients had pain. As soon as they came on the gurney and basically to recovery, they were already in pain. And he kind of followed the pain curve, but you can see as you get out about 12 hours, it's pretty minimal. So it's covering those patients initially, and then by following morning, they're significantly better. This is what we happen to use. We use acetaminophen. We were using Ofirmev IV, but PO works just as well, and it's a lot less expensive. There was a nice paper from Kim. He actually came to our lab from Korea. It was pretty amazing. He used Decadron, and we started using that because the pain is mediated primarily through inflammation, and that seems to help. We're actually looking at it intra-arterially to see if that makes any difference or not. I don't know. We use Toradol, Ativan, Benadryl, and a scopolamine patch. We keep kind of going back and forth on scopolamine. We like to give them the script when they're in the office, and then they place it the day before the procedure so it's on board by the time they get to the center. but we used to use Zofran and even Phenergan suppositories. You just got to see what works for you. Some things in the parenthesis here, some people do nerve blocks. We don't use that. I'm not sure it really has a place in the OBL because there are some systemic cardiac toxicity, neurotoxicity, and so you're on an island. I'm not sure, but some people swear by it, and that's great. It does work. Other people use epidurals or spinals. That would just be another complexity that we don't need in our OBL. We still use fentanyl Versed during the procedure. We might give a little Dilaudid. And then at the end of the embolization, we give intraarterial lidocaine, 5 cc's of 1%, preservative-free. And now we're looking at intraarterial Decadron just prior to Lido, but I don't have any data to know if that makes any difference or not. After the procedure, while they're recovering, they might get narcotics for pain relief. We use Dilaudid. If there's any kind of blood pressure issue, you give them morphine. That helps with the blood pressure. You might use Robaxin if you don't want to use a narcotic. The post-discharge, you need a combination of a narcotic and an NSAID. And there are a number of different ways to do this. We use plain oxycodone because we've given acetaminophen. And then we use meloxicam. It's just because it's a daily dose. We used to use prescription strength Motrin. It was every 6 hours, but from a compliance issue, meloxicam is a lot easier since it's a daily dose. Some people use fentanyl patches. I'm a little skittish about that. You know, the patches are not made for opioid naive patients, and our patients are all pretty much opioid naive. They last for 72 hours, which is great. You do cover the time you need to be covered, probably much more so. But there's also a potential for abuse, and so I just don't think it's a wise decision, but some people do use that. So in summary, UFE can obviously be very safely performed in the OBL setting. We've got a long history of doing this as outpatients. If you're starting out, you certainly want to be careful about your case selection. Go for that low-hanging fruit. Set the appropriate expectations with the patient and their family, the caregivers. Please use MRI. It's really important. It definitely will affect what you do and how you do things. And then make sure you have a defined protocol for these post-procedural issues. Thanks. This is a really easy question to answer for me. 100% in the OBL. I've been practicing over 30 years, so it's a little different, but all I do is fibroids and adenomyosis, 100% in the OBL, no hospital work at all. It's true paradise. Now, for somebody coming out of their fellowship, maybe not the first thing you do is go into an OBL, unless you're with say a bigger practice that can support that. I wouldn't just go off, I'm gonna do solo, right from my fellowship, solo IR in an OBL. I was a solo IR for quite a while. I have a colleague now, in fact, shameless plug, we're looking for a third. So if you love to do fibroids and only want to do, well, almost only, my colleague does some orthopedic embos, but focusing in the fibroid world. And for me, just to explain that a little bit, I started traditionally, but you evolve over time, and as you get older and grayer, you decide kind of what makes you happy. Fibroids made me happy. It's a tremendous procedure with a tremendous need in a population that's extremely underserved. And I'm in Atlanta, and so it just made sense. I enjoyed doing this, and it became a point where a number of years ago I decided, you know, I want to do what makes me happy, because when you're happy, it radiates. You come to our center, you will see the happiest people you'll ever meet in your life, much happier than the hospital. And they were still a reflection. When I worked in a hospital, they were a reflection of me, even though I didn't have anything to do with their hiring and firing. But now I have control over control of the entire product, and it's a tremendous product. We have a great story, we do great, and it just begets upon itself. It's positive reinforcing. I do a talk about ikigai, finding your ikigai. And if you look it up, it's a Japanese term that defines like where your reason of being. And there are 4 it's like a Venn diagram, and the intersection of these four things, what you love to do, what society needs, what you can get paid for, and can't remember the fourth, but in that intersection of those four things is Ikigai. I am right there because I love what I do. I love going to work. It's tremendous, and you find satisfaction. So I would suggest first, get the best training you can possibly get the best fellowship. Hopefully you're in a really good fellowship experience, and then get to decide, do everything. I think that's important. Find out then what you love to do most, because when you're doing what you love to do, your patients, you get the best patient care then, because you're not frustrated. It's not like, my colleague over here with the, trash collection. You're not a trash collector, because people who collect trash are unhappy. At least IRs that are trash collectors, they're miserable, right? So there's no time to be miserable. And it's best for patients when you're doing like what you love to do.